Good morning. We will have a short discussion about an impaction. Impaction, which is nothing but a pathological situation where a tooth fails to attain its normal functional position. So the tooth will not be in the occlusion. There are various definitions which has been given by the various authors for the impactions, which includes the Rounds definitions, Archer, Anderson, and the Peterson. Among the four authors, the most commonly used definition for the impaction will be the definition which is given by the Archer, which states that a tooth which is completely or partially unerupted beyond its chronological age and its position against another tooth, bone, soft tissue, so that the further eruption is not possible for that teeth. It is in a order of the frequency order how the impacted teeth will be. The most commonly impacted tooth will be the mandibular third molars, and the least commonly impacted tooth will be the maxillary lateral incisors, followed by the third molars, the maxillary third molar, maxillary canine, mandibular premolar, maxillary premolar, mandibular canine, and the maxillary central incisor, and the last, the maxillary lateral incisor. Coming to the theories of the impactions, various theories are there to define the impactions and how the impaction has been occurred, which includes an orthodontic theory, which states that the jaw usually develops in the downward and in a forward direction. Whenever there is any interferences which occurs for the growth of the jaw, which will result in the impaction. And then phylogenetic theory, which states that whenever the more functional masticatory force, better the development of the jaw. So the nature which is tries to eliminate the organ which is not used. So due to the changing in the nutrition habits, the use of the powerful jaws have been eliminated, and thus over the centuries, the maxilla and the mandible will get decreased in size, leaving an insufficient space for the third molars. Coming to the pathological theory, something which is opposite to that of physiology. So it may be due to the infections or inflammation induced. Infections, as a result of a chronic infections, there will occur in a condensation of osseous tissues, which will further prevent the growth and the development of the jaws. Coming to the Mendelian theory, where he states that hereditary plays a very important role for the tooth to be get impacted. This because the individual will use to get a small jaw and the larger teeth from the parents. This may be an important etiological factors in the occurrence of the impaction. The last theory is the endocrinal theory. Endocrine, something is related to the hormones. Whenever there is an increase or a decrease in the growth hormone secretions, which in turn affect the size of the jaws, which will result in the reduced space for the third molar to get erupted into these functional positions. As a result, impaction will occur. What is the cause behind the impaction? It may be a local cause or it may be a systemic cause. Local, which follows an obstructions, lack of a space, ankylosis, retained tooth, non-absorbing bone, ectopic position of teeth, dilaceration of roots, soft tissue or bony lesions, or an habit. Systemic causes, it may be a prenatal, which may be an hereditary, or maybe a postnatal due to certain infections, or maybe a congenital syphilis, anemia, and the malnutrition. Endocrinal, as I told you, due to the increase or decrease in the secretion of growth hormone. The rare causes will be cleidocranial disorders, osteopetrosis, achondroplasia, cleft lip, and the palate. And when to do an removal of extraction, removal of the impacted tooth, and when not to do a removal of impacted tooth. So there are certain indications and the contraindications. Indications, first and the most common indication is that whenever the patient present to us with a recurrent pericoronitis, if the patient is present with more than 2 times of a recurrent pericoronitis, the absolute solution for the pericoronitis will be the removal of that impacted tooth. So pericoronitis, which is nothing but there is an inflammation of the soft tissue surrounding the impacted tooth and the tooth in the line of the fracture. The tooth which is present in the line of the fracture will sometimes interfere with the reduction of that fracture bone. In such a cases, the tooth has to be removed, and the deep periodontal pocket or prior to that of an orthodontic treatment in order to provide a sufficient space for the movement of the tooth and the prevention of root resorptions and the caries or a retained deciduous teeth and management of the cyst and the tumors associated with that impacted tooth, and the management of pre-prosthetic concerns and the prophylactic removal in case of a patient who is going for the orthodontic surgeries. And the contraindications, extremes of the age. So as the age increases, the bone will become more sclerotic. As a result, impacted tooth removal will become more difficult. In such a cases, it's better to avoid the removal. Or a compromised medical status, excessive risk of damage to the adjacent structures, or whenever there is a question about the future status of the second molar. So uncontrolled active pericorneal infections, socioeconomic status, fracture of atrophic mandible, and abutment selection. There are various classifications are there for the mandibular third molars and for the maxillary impacted third molars. For mandibular third molars, it has been given by Winters in the year of 1929, Pell and Grigories in the year of 1933. Winter, who gave the classifications based on the angulations, where we have to draw a straight line along the long axis of the second molar and the third molar. If the straight line which has been drawn along the long axis of second molar and third molar which meet at the top, it indicates that impacted tooth will be a mesioangular. If it is meets at the bottom, it will be a distoangular. If it is meet at the right angle, it will be an horizontal. If it is a parallel, it will be a vertical. So coming to Pell and the Grigory, who gave the classification in the year 1933 based on the depth. Depth. It has been classified into level A, B, C. A, the highest position of the tooth is on the level or with or above the level of the occlusal line. You can able to see this diagram where the highest position of the tooth is on the level of the occlusal line. So in the level B, the highest position of the tooth will be below the occlusal line and the above the cervical line. In the level C, the way the highest position of the tooth will be below the occlusal and the below the cervical line. Coming into the space availability. Availability space between the second molar, the distal aspect of second molar, and then ascending border of ramus of the mandible. So if there is a sufficient amount of the space is present, the molar can get erupted, so it will not get impacted. So in such a cases, it has been classified into class 1. If it is a class 2, where the space available between the anterior border of the ramus and the distal side of the second molar is lesser than the mesio-distal width of the crown of the third molars. The third, class 3, where the third molar will be completely embedded in the bone from the ascending ramus because of the absolute lack of the space. This is the classification for the mandibular third molar. Coming back into the maxillary third molars. It is also the classified based on this angulation, which is as same as that of the mandibular third molars, where it has been classified into vertical, mesioangular, horizontal, distoangular, and if it is buccoverted or palatoverted or lingoverted and inverted, based on the occlusal plane, where it has been classified into class A, B, and C, and based on the relation to the sinus. So sinus is the most important structure which is present in the maxilla. So whenever there is a sufficient space which is present between the sinus floor and the impactor maxillary third molar, so it indicates there is no sinus approximation. If the space which is presented between the maxillary third molar, maxillary impacted teeth and the sinus floor, if there is no sufficient space, so it indicates that the sinus approximation. So the third molar is just more nearer to the sinus. So coming into the difficulty index. So that this indicates that there are certain difficulties are there for the removal of that impacted tooth. So the treatment plan will always follow these difficulty index. So which has been given by the Pedersen in the year of 1988, Parent and the Winters Warlin. Pedersen, where you have been given the class difficulty index based on the spatial relationship, depth, and the ramus. So where the difficulty level will be classified into very difficult, moderate difficult, and the minimally difficult. For an example, if a patient comes to us with a mesioangular, as I told, level A, which indicates that the highest point of the tooth will be at the level of the occlusal plane. And the patient comes to us with a class 1, which indicates that there is a sufficient amount of space which is present between the distal aspect of second molar and the anterior border of the ascending ramus. So which follows? So the mesioangular is number 1 and the level A is number 1 and then class 1 is number 1. So we have to add all these 3 scores. So number 1 plus 1 plus 1, which indicates the total score will be 3. So the difficulty level will be minimally difficult. So it indicates that 3 to 4 will be minimally difficult. So it means that the removal of that impacted tooth will be easier compared to that of the distriangular or horizontal or level C or a class 3. So parent scale, where the difficulty is just based upon the extraction types. Whenever the extraction is which has been done, which is with help of the forceps, it is indicated as an easy extraction, or osteectomy, it is easy too. And then osteotomy and the corneal sectioning, which is based on the difficulty index 3, and the roots, whenever the impaction tooth removal requires sectioning of the root, it follows the difficulty index 4. And coming to the Winter's bar line. So Winter's line or the VAR line. VAR line is the most important for the impacted tooth, which will be traced with help of the IOPA, which means that intraoral radiograph, perioptical radiograph. So which is with help of IOPA, we can able to trace these VAR lines. So VAR line, W stands for the white line, A stands for the amber line, and then R stands for the red line. White line, which indicates that differences in the occlusal line, whereas amber lines, which indicates that the alveolar bone covering the amount of alveolar bone covering the impacted tooth. The red line, which indicates red line. Red line indicates the depth of the tooth in the bone. So we have to measure the red line, which has to be drawn perpendicular to that of the line which has been drawn along the occlusal level. So whenever we have to measure the red line, so if the red line, which is more than a 5 mm, it indicates that the extraction is very difficult. So for every additional 1 mm, for example, if the red line measurement is 6 mm, so additional 1 mm of more than a 5 mm, so the difficulty index will be increased by 3 times. So it indicates that whenever it's that the red line is more than a 9 mm, the extraction has to be done under the general anesthesia, not under the local anesthesia. So coming to the another assessment, which is like WAFI assessment, where we have to do an assessment in the panoramic radiograph, which is panoramic view, which is nothing but an OPG, orthopantomograph, which is will be used for the tracing this WAFI's assessment. WARFI assessment. W stands for the Winters classifications, H will stands for the height of the mandible, A will be the angulation of third molar, R will be the root shape, F will be the follicle size, P will be the path of the exit. Each one will have the difficulty scores. So based on that, the difficulty index will be increased. So Winter, for example, if it is an horizontal and then height of the main mandible is 1 to 30 mm, or the angulations of the third molar is 1 to 59 degree, or a root shape which is a complex one, or a follicular size is a normal, or a path of the exit is that the space available, or a distal cusp is covered, or a mesial cusp is covered, or both the distal and the mesial cusp is covered. So that based on that position and based on that millimeter space, height of the mandible, based on the angulations, shape, and the size of the follicle surrounding the impacted teeth, and based on the path of the exit, the difficulty score will get vary. So coming to that, there is another most important things. If we are going to deal with a mandibular third molar, one should keep in mind that how far the third molar is from the inferior alveolar canal, since the most important nerve structure which passes through the mandibular bone. So which has this depends upon the relationship to the inferior alveolar canal. The Poynton, who gave the classifications in the year of 1960, where he related to the root and the relation to that of the nerve. So always the classifications coming to the relation to root. Whenever there is a darkening of the root, or a deflection of the root, or a narrowing of the root, or a dark bifid root apex. Coming into the relation to the canal. So relation to the canal, where there is an interpretation of white line of canal, diversion of the canal, or the narrowing of the canal. This is the pictorial representation of the Poynton's, the relationship of the root to the inferior alveolar canal. Here you can able to see the darkening of the root, and here you can able to see the deflection of the root, and this is a narrowing of the root, and this is the dark bifid apex. And the relation to the canal, you can able to see the interpretation of the white line of the canal, where the impacted teeth is get interfering the white line of the canal, and the diversion of the canal and the narrowing of the canal. Coming to the most important, the surgical part. This first step will follows the IANB. So inferior alveolar nerve block has to be given to the patients and followed by the incision. Incision, which always will depends upon the depth of the impacted teeth. There are several principles for the flap designs. The most important will be the base of the flap. It should be always broader than that of a free margin to preserve the adequate blood supply. And then the flap should have an adequate size and it should be a full thickness mucoperiosteal flap. It should be made over the intact bone and it should avoid an injury to an local vital structures. It should always place away from that of a lingual aspect of the mandible in order to preserve the damage to the lingual nerve. There are various types of flap, which includes L-shape, bayonet, envelope, triangular, comma shape, and the ward incision. And then one incision is the ward incision, which is the most commonly used incision for the impacted tooth. There are two types of the wards incision, which is a wards and the modified ward. So it's always the depth of the impacted tooth will decide the type of the incision, where the incision will get starts from the distal aspect of the second molar teeth, and then from the distal aspect of second molar it should be curving downwards forward to the level of the apex of the distal of the first molar. So this type of an incision is used whenever the linguoverted tooth impaction is present. The posterior part of the incision is same, but the anterior part commences as the junction of the anterior and the middle third of the second molar and runs down to the apex of the distal root of the first molar. So first step is the flap designs and the incision design. To summarize the flap and then incision, the most commonly used incision for the impacted mandibular third molar will be the ward incision and the modified ward. The incision will always based on the depth of the impacted tooth. Coming into the ward incision, the anterior part of the incision will be starts from the distal aspect of the second molar and it should be curved along the cervical margins of the third molar, and the last part and the posterior part of the incision should be placed towards the cheek region, not along the ramus of the mandible or not along the retromolar region. The most important structure is that the retromolar arteries and the veins will pass through these structures. So whenever the incision is passed along the retromolar region, the patient will have a profuse bleeding which will interfere with the surgical site. So the second one is that the flap reflection. So the flap should be reflected as much as possible for the tooth to be visualized. The third step will be the bone removal. It can be done either with the help of a burr or either with the help of the chisel. Each one will have the certain merits and the demerits. If the burr should be used, the length should be a 7 mm, the diameter should be 1.5 mm, and the commonly used is start with a rose head burr and followed by the 701 or a 702 burr. Chisel technique, the width will be 6.4 mm, the length will be 17.5 mm, angulation of the chisel should be at a 45-degree angulation. And there are several other techniques. Whenever we are using a burr, so there should be a sufficient amount of an irrigation in order to prevent the bone. So heat induced injury to the top of bone. So irrigations will be either with help of the saline or with help of the sterile water or a ringa lactate solution or a povidone iodine. So why to do an irrigations? So with help of irrigation, you can able to cool the burr. Another thing, as I told in previously, the bone damaging can be reduced and then efficiency of the burr can be improved. So there are several other techniques for the removal of the impacted teeth. As I told, either you can do with a chisel or you can do with a burr. Each one has a certain merits. So the techniques will be a lingual split or a Kelsey-Fry technique, which has been popularized by the T. Ward. So it is called as a Tharas Ward and which is proposed by the Sir William Kelsey-Fry and followed by the most commonly indicated for the tooth which is deeply positioned and it's horizontally or distangularly impacted. So what are the steps which is followed in a lingual split technique? First is that vertical stop cut, horizontal stop cut, remove the buccal plate, fracture the distolingual bone, remove the bony wedge, elevate the tooth, reposition the flap, and then finally the final most procedure is the suturing. Here you can able to see and visualize the steps which is involved in the Kelsey Fry technique. The first one will be the vertical stop cut, as I mentioned previously. The second one will be the horizontal stop cut. Third one is that you have to remove the buccal plate. The fourth one is that you have to fracture the distal lingual bone. And then fifth one was that you have to remove that small bony wedge. And then sixth one, elevate the bone, elevate the tooth. And then again, the final most procedure is that you have to reposition the flap and you have to suture it. Another technique is that lingual trephination technique, which has been given by the Boulder Henry. It is indicated for the patient who present with the age group of 9 to 16 years, and where you will place an S-shaped incision. It's made from the retromolar fossa across the external oblique ridge, followed by the elevate the flap and place a define the buccal cortical plate over the third molar region, and the burr is used to make a vertical cut anteriorly and the posteriorly, and using a chisel and osteotomy is applied to the vertical directions over the burr hole. Then the buccal plate is fractured out, expose the third molar cut completely, and elevator is applied to deliver the tooth out of the crest. Any follicle remnant, if it is present, it should be carefully scooped out and with precaution to avoid the injury to that of an inferior alveolar nerve. This is the pictorial representation of the lingual trephination technique. The first step in this is that modified S-shaped insertion has to be placed, followed by the elevate the flap, and the buccal cortical plate is trephined over the mandibular third molar region, and followed by the removal of that buccal plate, and then elevate the tooth, remove the tooth. And the final step, after the removal of the impacted third molar, what are the possible complications we can expect? The complication might occur intraoperatively and as well as postoperatively. Intraoperatively, during the placement of incision, there are chances for the injury to the vessels. As I told that in case of a ward incision, the posterior limb should always placed along the cheek region, not along the retromolar region. If you place along the retromolar region, there are chances for damaging the retromolar vessels. I'm mentioning it again and again, and then there is a chances of profuse bleeding can occur. And during the bone removal, sometimes there is a chances of the slipping of the burr. So sometimes the burr will get slipped off and it get damaged the adjacent soft tissues, and then it causes a damage to that of the soft tissues as well as to that of the second molar. During an elevation, whenever we give an excess of force for the removal of the third molar without supporting the mandible, there are chances for the bone to get fractured. So fracture of the mandible can occur. Sometimes there are chances for the tooth to get forced into the spaces which is present below the mandible. So which is called submandibular spaces, or the damage occurs to the inferior alveolar canal. During a debridement, the forceful debridement will cause the injury to the inferior alveolar bundle. These are all the possible complications that might occur intraoperatively, and then a postoperative complication which follows. Everyone knows that whenever we are doing any procedure intraorally, the first and the foremost complication will be the pain, followed by swelling and hematoma, bleeding, trismus, infection. The most common is the dry socket, and followed by the TMJ pain, as the patient has to open his mouth for the longer period of the time, paresthesia if the inferior alveolar nerve bundle is get damaged, and then sensitivity. So how to prevent this or how to reduce this? The first and foremost step is that immediately following a removal or surgically removal of impacted teeth, we have to advise a patient to reduce the swelling. So in order to reduce the swelling, we have to advise the patient to take up the medications as well as the applications of the cold over that swelling, and followed by the applications of the heat. So the compressions with the cold will reduces the vascularity over that region, and it will reduce the swelling. So after the 2 days, after the 24 hours, we have to advise the patient to keep the warm water irrigations. So the warm water saline irrigations will cause vasodilatations and increases the vascularity in the regions, and it helps us to remove the debris in that region. Followed by the bleeding. So always pre-operate, intraoperatively, we have to try to reduce the bleeding, and post-operatively, we have to advise the patient not to spit immediately. And then a trismus, it is always better to make sure that you know the anatomical landmarks before inserting the needle inside the mouth. If not, there are chances for damaging to the tough fibers and the trismus will occur. Infections, always do the procedures under the pre-operatively. You have to do an autoclave all the instruments. You have to do the procedure in a clean manner. Dry socket, as I told you. So advise a patient not to spit, not to smoke for the next 3 days. So that will prevent the dry socket in the development. And the paresthesia, and try to avoid the damage to the inferior nerve. So make sure that preoperatively you have done all the investigations related to the inferior nerve. CBCT has to be done, or an IANB, and all the assessment has to be done to find out the relationship of the third molar to the nerve to avoid that complications. And then sensitivity will be the last complications which might occur whenever we damage the second molar teeth. So try to avoid the damage to the second molar teeth and try to do an impaction with a pain-free and with a reduced complication for the patient.